Alternative therapies for OSA. So you're probably can even celebrate in your seat. This will be the last talk that we have about obstructive sleep apnea for the summer. We started by introducing OSA and talking a lot about PAP and all the PAP therapies and titration protocols. Well, this talk is going to be on all of the alternative therapies, what we can offer to our patients aside from PAP.
I start all of the treatment talks about that OSA is a chronic disorder. We need to figure out, the physicians need to figure out what degree of care is acceptable to the patient to try to make sure that their long-term chronic disorder is cared for on a long-term basis. We're not throwing a treatment at them that they're not going to stick with, or because then it won't do anything for them, or in the long term won't work for them. So in some populations, being able to care for their disorder can be difficult. So in those patients, we need to incorporate their family, their caregivers, other healthcare members of their care team, to just figure out what is going to work best for each specific patient, especially when we have patients that are more special needs, high needs, complicated. So like patients with Down syndrome, Alzheimer's disease, any type of handicaps. Sometimes, remembering to put a PAP mask on every night can be difficult. Actually having the dexterity to be able to do it can be difficult. If you have somebody that's living in a more assisted care facility, you need to make sure that their care facility is on board with whatever treatment plan this patient is going with and is involved in the education component of it. Or if they're living more independently, who is their support team? And if they don't have a good support team, can we really expect them to be able to do everything we're asking of them? Or should we look at more a milder approach to, or a different approach to the treatment of their apnea? Can this patient put on the mask itself? Do they have that dexterity? I just had a patient yesterday whose hands were totally crippled from arthritis. So it's like, good thing you're in prison, so you have a lot of people here that can help you put the mask on. But essentially, what we really want to see is, are they doing better with whatever treatment we go with? Like, yes, PAP is the number one treatment that we go with. It's non-invasive. It has a really good efficacy rate for patients when they are compliant. But if they aren't compliant, then it's not going to do them any good. But we want to make sure that their signs, their symptoms, all the things that brought them to the sleep lab in the first place are resolved, that their apnea is close to being eliminated, their oxygen is normal, healthy, that they're not having any of the negative or detrimental consequences that can occur with obstructive sleep apnea. So we need to make sure, regardless of whatever therapy the patient goes with, that they are following therapy, they are being adherent to it, compliant with it, that they aren't experiencing excessive side effects or complications because of their untreated OSA or because of their treatment in and of itself, and that they do feel continued resolution of symptoms. So if they were to feel that their symptoms were to return, further investigating what might be causing that. So even if patients are able to eliminate their obstructive sleep apnea, it is a possibility. Whether it be through weight loss, surgery, they still need to be followed up with routinely, not as often, but just every so often, once a year, every other year, just to make sure that whatever they had didn't return, because things change. Even with weight loss, you now have the effects of aging working against you. There could be other comorbidities that could then bring on or exacerbate apnea, where with weight loss alone it was once eliminated. Well, now they have some mild issues coming back. Even surgery. So surgery isn't 100%. And with surgery, the outcome isn't always immediate. There's a continued progression of how the surgery might affect the patient as they heal, as scar tissue might develop. So they might find that their symptoms even further get better, or they might find that they have initial relief, and then there's a regression on their resolution of symptoms. So we went through this flowchart the last time, and what we talked about already is CPAP. What we're going to talk about now is if they choose to refuse CPAP or if they fail CPAP in any way, what are the alternative methods that we can offer them? So we've talked about PAP, we can check that off. We're going to go through the rest of the list. So just general measures would be avoiding alcohol, avoiding medications that could exacerbate apnea, trying to get them into a smoking cessation program if they're a smoker. And if there's any type of precipitating factors that might exacerbate or worsen their apnea, like if there's a comorbidity, hypothyroidism, that makes their apnea worse, well, let's treat the hypothyroidism at its source and get that under control. And if you probably noticed when you're reading through your reports, the office visit reports, they pretty much recommend this for all patients, in addition to whatever therapy choice that they're going with. So avoiding all these things that can certainly make everything worse. So how alcohol exacerbates apnea is it not only further relaxes the upper airway muscles, so makes them more collapsible in and of themselves, it increases airway collapsibility. So again, your upper airway is just this one floppy tube, and there's things that can make it floppier, and there's things that can make it less floppy. And alcohol is one of those things that just makes it more prone to collapse in and of itself, in addition to further relaxing the upper airway muscles. In addition to that, patients, when they're under the influence of alcohol, are less responsive to be able to wake up. So whereas an apnea or a desaturation might cause the patient to wake up, you might see that they have more prolonged events and more severe events, more severe desaturations, because they're just not waking up as easily to these physiological triggers. So in so doing, it can make your apnea longer, it can make the oxygen desaturation significantly worse. Pretty much the same thing for muscle relaxants, sedative, hypnotic agents, those type of medications that are sedating. They will also reduce the muscle tone of the upper airway and act very similarly in how alcohol affects the body in making apneas worse. It can also bring on a central component in that, in taking in high enough doses or in combination with certain things, we could totally knock the drive to breathe out. So in addition to exacerbating the obstructive end of things, you could also be bringing on a central end of things by taking certain medications. Smoking can cause the airways to become inflamed and become edematous. They also cause irritation and congestion by becoming a smoker. So by quitting smoking, you can reverse all of this. I have yet to ever really counsel a patient on smoking because I'm sure they've heard it all before with every single healthcare practitioner they've ever come into contact with. And you usually get the eye roll and the yeah. So I kind of leave it be, They're going to do what they want to do. They know their risks. Other precipitating factors would be sleep deprivation. So sleep deprivation can bring on a lot of abnormalities in our sleep. But also just think about what happens when we are sleep deprived and we go into recovery sleep. So recovery sleep, following a period of sleep deprivation, our sleep architecture changes, where we have REM rebound and we have an increase in slow wave sleep, stage 3 non-REM sleep. So what that can do is REM rebound, especially you have a REM component to apnea, can certainly increase the AHI for that night because of that. Also, stage 3 is the absolute deepest sleep we have, where our arousal threshold is very low. It's very hard to wake up out of stage 3 sleep. And so if you're to have respiratory events during stage 3 sleep, again, the same thing with alcohol, the thought behind that is they can be more difficult to wake up from the physiological triggers of these prolonged apneas and desaturations. No, alcohol, while it's being metabolized in the first half of the night, causes a lot of stage 1, 2. Very light, broken sleep. but you inebriated, you kind of sleep right through it. Like you feel like you're sleeping well, but you're not. In the morning you feel it. You feel how tired you are. And then after the alcohol is mostly metabolized, the second half of the night is when you get that rebound sleep deprivation style of sleep where you have significant amounts of REM sleep where it's kind of all piled in at once, significant amounts of stage 3. Hypothyroidism, which is a disorder, an endocrine disorder, can certainly make apnea worse. Hypothyroidism kind of slows everything down, causes a lot of weight gain, all things that are not good for an apneic patient. So what can happen is if you just kind of get these other comorbidities better under control, you're better able to control the apnea. Other therapies we're going to go through, so weight reduction. Pretty much every patient is counseled to lose weight. Easier said than done, but even just having a small weight loss, 5 to 10% of their baseline weight. So if you have a 300-pound person, 10% of their weight is 30 pounds, 5% is 15. That's still a significant amount of weight loss. And it can improve the patient's apnea indexes or indices. There's no magic number. It's not like we can say, okay, if you just lose 20 pounds, your apnea will be way better, or if you just lose 10% of your weight, you'll see a significant improvement, because it just really does vary across every patient for what specific amount of weight loss is going to have that effect on their AHI, that profound effect that they really like. So generally, if a patient's had lost weight between 20 to 50 pounds, that's when they recommend doing a repeat sleep study just to see where they're at and see if therapy is still necessary or what level of therapy they need. So you'll mostly see, though, that weight loss alone is not enough to reverse sleep-related breathing disorder in patients that are anatomically predisposed to OSA. So some patients have their OSA is twofold. It's not only because they're overweight, but it's also because of their anatomy, where even if they lost weight, they're still going to have apnea, but in all likelihood it will be to less of a severe degree. The other thing is morbid obesity. So these patients that are coming in that are 300, 400, 500 pounds, they lose 20 pounds. I don't want to say that's just a drop in the bucket, because any amount of weight loss is important and is significant, and it should be celebrated. But for these patients, more weight loss is typically needed to see an appreciable effect. However, I've had patients that are 500 pounds and never snored, never had one apnea. So you can't assume anything. Everybody is just built differently. So again, whatever weight they need to lose, it's just different for each person to be able to really see that appreciable effect in their AHI and their values. But one study did find that about a 3% change in the AHI was associated with each 1% change in weight. So if they lost 1% of their body weight, overall body weight, you'll see a reduction by 3% of their AHI. But there hasn't been too many studies, it hasn't been so consistent to show this, because there's been so many studies that really has tried to find that magic number. It would be so nice if we could have one of those beautiful charts, that correlates weight loss and AHI, and they just really haven't been able to show an appreciable correlation. That was one study, and they've done numerous studies on that. So it has an effect. They have shown, what it has shown is there is an effect. Losing weight does improve those numbers. So typically we do a follow-up sleep study in patients that have had a substantial weight loss, so 10% of their body weight. And 10% seems not a lot, but a 300-pound person, that's 30 pounds. That's a lot of weight. If they have a weight gain and they're feeling like their symptoms are starting to return, if they're not really feeling a response to their therapy, if their symptoms return despite having a good response, so just repeat sleep studies always help. But the way that weight reduction can help is, we've heard all along weight and apnea, and we started to touch on it before, but on why and how weight specifically will impact and can cause apnea, but also how the loss of weight can improve parameters for apnea. So not only does it reduce the amount of fatty tissue that is located in the upper airway, because remember, when we gain weight, we gain it in places all over. We gain it in places that we can't even see, and that includes in the soft tissues of the upper airway. And it can also help improve the quality of the upper airway by reducing the collapsibility of the airway, because you have less pressure against it. So it's able to stay open more. It becomes less of a floppy airway. And it takes more than, as you lose weight, it takes more to be able to close that critical closing pressure, to be able to cause that airway to collapse. Not only improving lung volumes, your FRC, your residual volume, your vital capacity, but it helps improve the work of breathing as well, because you have less that you need to working against you to be able to take these deeper breaths. So the ASM recommendations in regards to weight loss is that they do recommend weight reduction that can improve AHI in obese patients, and it should be used in conjunction with a primary treatment for OSA. So it should not be your primary treatment, because going out and saying, okay, well, you have apnea, go out and lose some weight. Well, okay, that's not something that's going to happen overnight, and that's not something, weight loss is not something that has really been, that a lot of people have long-term success with it. So it needs to be something in conjunction with a primary treatment, like, CPAP and a weight loss program, oral appliance device, and having a meet with a nutritionist. So some of the labs have started to incorporate nutritional counseling into their care, their services provided. Like St. Peter's brought a nutritionist on, because they really try to hit all the different components of this disease from all angles. Well, we have already talked about all the different negative consequences of apnea and insulin resistance. Insulin, they're really finding that obesity is a hormonal disorder, and a lot of it comes back to insulin. And so with apnea causing insulin resistance to worsen, it can worsen obesity profiles. So to even just have the energy to be able to stick to a good eating plan, because what happens when we're tired, guys? What is the food that you gravitate towards? Do you when you're tired, you just don't have that mental stamina to be able to, let me eat this broccoli instead of this cookie, I'm going to be good. Let alone having the energy to exercise, to be able to do everything that we need to do to try to live a healthy lifestyle. So, it should be emphasized, but it cannot be the primary treatment. Exception to the rule, though, is bariatric surgery. And you're finding that in bariatric weight loss surgery, all these patients, if any bariatric surgeon specialist is worth their salt, will make them jump through the hoops necessary prior to doing the surgery, which includes a sleep study. And for these patients, they might end up on CPAP therapy temporarily, but they typically will have such a significant amount of weight loss, they end up, the better treatment option for them is AutoPAP, to auto-adjust on automatic, so they're not having to come back in for sleep studies like every month. And they usually can quickly come off of whatever treatment they're on. Some of them don't even, immediately following the bariatric surgery, depending on where their apnea was before going into it, they don't even continue with therapy after the surgery, because they're going to have a quick resolution of that disorder. Alright, oxygen therapy. So oxygen therapy can be considered in certain patients that are hypoxemic, that CPAP or BiPAP alone is not controlling their oxygen desaturations. But there really isn't a consensus regarding what level of oxygen desaturations benefit from oxygen therapy, like if the patient should be on oxygen alone because they had such severe desats, or should we try treating with PAP. But oxygen does not control obstructive sleep apnea, so you're really like putting a Band-Aid on a bullet wound by throwing oxygen on a patient that has obstructive sleep apnea, because what it does is you can risk actually making the apnea somewhat worse, in that it prolongs the apnea duration, because some people, that desat is that physiological trigger to cause a patient to wake up. When you apply supplemental oxygen, it keeps their oxygen levels steadier, and so they don't have that physiological trigger as quickly to wake them up. So you start to see that their apneas actually start to become more prolonged. The other problem with administering supplemental oxygen during a baseline test is that it will minimize the desaturation. So whereas a respiratory event might be a hypopnea, it's no longer, doesn't meet those rules and guidelines to be able to score it as a hypopnea because the desat was masked. So their apnea comes back as being erroneously milder than what they truly are at. So the ASM recommendations regarding supplemental oxygen is that it is not a recommended primary therapy for OSA. It's really only adjunctive if necessary in very specific circumstances, like hypoxemia. Their hypoxemia isn't controlled through PAP alone. Medications. So they've been, our population tends to look for a pill for everything. And so in trying to meet that need, they have researched several medications to try to see, can this work? Can we create that magic pill? Because I think if they did, it would be a billion-dollar industry where patients would be you'd see a bunch of CPAP machines in the garbage cans because they're like, oh, I can take a pill. I don't need to put this on anymore. But there really isn't any medication that's entirely effective in treating apnea. They have studied medications that could possibly have some appreciable effect on your upper airway muscle tone during sleep to keep your airway open. They've trialed medications that might increase your ventilatory drive. For patients that have REM-related apnea, tried medications that reduce the REM, so then that way, they're not having the REM-related apneas. And also stimulants to try to alleviate the negative consequences of having apnea and having the resulting sleep fragmentation. So some of the medications that they've trialed is, one of them is acetazolamide, which produces a metabolic acidosis, which causes the body to try to compensate for the acidosis by increasing the respiratory drive. Caffeine is a stimulant. The other one is Provigil, is a huge one that's out there right now. Antidepressants, fluoxetine, to try to decrease the percent of REM sleep. Other stimulants, nicotine. They found tryptophan helps improve OSA, and tryptophan is what is converted into melatonin as well, so it can improve melatonin levels. Imipramine, for whatever reason, it's an antidepressant that they found decreases apnea and improves symptoms in certain patients with sleep-related breathing disorders. But with any medication, you have to be really careful. And they're finding that just even with like the medications for smoking cessation, it starts with a C, right? Chantix. Well, Wellbutrin is another one. So Wellbutrin is an antidepressant, and they found as a side effect it reduced cravings for cigarettes. But if you're giving a patient that's not depressed an antidepressant, you can cause some really negative mental side effects. And it's like, whoa. And so the fact that somebody would rather take a pill that's actually causing like a metabolic acidosis, or, oh yeah, let me just not get into REM anymore. I mean, crazy. So obviously this line of treatment hasn't taken off. But in terms of what the ASM recommends, they do recommend those topical nasal sprays, the corticosteroids, like the Flonase nasal sprays for patients that have chronic rhinitis, chronic congestion, and that'll really help them acclimate and have better outcomes with PAP treatment, or even whatever treatment they go with. If they're better able to breathe through their nose and have better resolution of their rhinitis symptoms, the better outcomes they'll have. And then Provigil, or modafinil, is a stimulant that is approved to treat the daytime sleepiness if patients are on or have sleep apnea and are still having residual daytime sleepiness despite being on an effective PAP level. They have approved Provigil for that use. Provigil is also approved for night shift workers to help keep you awake during the night. So positional sleep apnea is when your apnea is about or more double when you're on your back compared to when you're not. And the reason why most people are worse when they're on their back is just because the effects of gravity. You've got the weight of the tongue that's now also could cause some displacement. So people that have just straight positional apnea, where they might not have apnea at all when they're on their side or prone, tend to be less overweight, so more towards a normal range of their weight, and have a lower overall AHI than patients whose apnea is present in all positions. So if you have a report and there's no supine sleep recorded, we can't say that there's no supine component. But what you'll typically see in the doctor's report is they'll make the note of no supine sleep, overall AHI was this. No supine sleep was recorded to be able to compare supine versus non-supine, but we can surmise or anticipate that if the patient was to sleep on their back, their AHI would be worse. That's what I've seen the physicians will typically write. So some things that you can do for patients where they do have a positional component is try elevating their head. One of the reasons why I like to record how many pillows the patient's sleeping on. If possible or if necessary, try to keep their sleep on their side versus on their back. And sometimes you'll use positional therapy in conjunction with another treatment. So like say you have a patient that's wicked severe apnea, and the level of PAP needed to break their airway open on their back is just off the charts. Sometimes what we'll do is keep them on their side and then just find the PAP level that they can use while on their side, because they're just so severe, them rolling to their back, it's still just a poop show. They really haven't done long-term studies on the efficacy of these positional therapies we're going to talk about, like are the patients really compliant with them or what, but they're easy enough and it's cheap. So the patient, tell them to buy a few tennis balls, throw them in a sock, sew it on the back of your pajama top, but make sure it's like a semi-fitted pajama top, so it's not like just a really loose one where it's going to go all over. So basically if they try to roll on their back, they're not going to be able to. It'll be uncomfortable if they do. It is. Another one would be fill a backpack up with styrofoam, so you're pretty much turtling yourself on your side. You cannot roll over to your back. They have trigger alarms that if the patient were to roll to their back, it would start to alarm. Other options would be to just elevate their head and their trunk a little bit more, so propping them up a little bit more with certain pillows. They have these certain positions or these specialty pillows, like a cervical positional therapy pillow. So what that does is it helps kind of extend the neck, because what you might find is these patients sometimes, like, they'll be sleeping and they'll barely move, but they'll move their neck just right that it's like all of a sudden you're having a ton of events. And so these pillows are supposed to more stabilize their neck and help them keep it more open. And how the ASM feels regarding positional therapy is that when you try to employ methods to keep the patient in non-supine positions, it is effective for patients who have an AHI that's really only present when they are supine. But you can also use it as a secondary therapy. So like I said, if you have somebody that's wicked severe, maybe, like, for instance, I already gave the PAP scenario, but now what about the patients, we'll talk about oral appliances next, I think, where oral appliances, they're really only effective for patients with mild to moderate apnea, but once they get to the severe end, they're not as effective as they need to be. So if you have a patient that's milder on their side, well, hey, let's keep them on their side and we'll do an oral appliance. So you can use it as an adjunctive or supplement to a primary therapy. So the next thing we'll talk about is oral appliances. There's a lot more out there that are coming out. They're typically custom made. The ones that are worth anything anyway are custom made, and they can help improve your upper airway patency or openness while you're asleep. So they enlarge your upper airway. And they help make it a little bit more stable, so it's less prone to collapse by improving your muscle tone of your upper airways. They are not as effective as CPAP. They're effective in about 80% of patients with snoring or mild to moderate OSA and about 30% of patients with severe. So they are not recommended for severe sleep apnea, those patients. And once patient hits the level of being in the severe range of things, they are very limited with their treatment options. There's a lot of things that are more designed and efficacious for mild to moderate, but once you hit severe, you're starting to limit your treatment options. How they work is they help position and kind of thrust that lower jaw or the mandible forward and help kind of pull the tongue forward as well to help kind of open up the airway a little bit more and prevent its collapse. How much you need to jut somebody's lower jaw out is individualized. So it's one of the primary factors of influencing how effective these devices are. So they're really coming a long way. The mandibular repositioning appliances are the most common ones you'll come across. What they do is they pretty much have these like upper and lower bite guards, so to speak, these coverings that go over their upper teeth and their lower teeth. And then they have a bar that connects the top piece to the bottom teeth. And so it uses the top teeth as an anchor to jut the lower jaw out with the bottom bar. And you can adjust how much the lower jaw is jutted forward.
So these types of appliances you typically would get through a dentist that is trained and qualified in sleep medicine, and they would fit it to you and start the process of adjusting that bar to displace the lower jaw. You can also get them over the counter. There's some of them that I do use in my one jab where it's a boil and bite, and it's kind of a set degree of displacement for how much the lower jaw gets displaced. There's other more simple boil and bite ones that the patient has control over and can kind of adjust this little wrench thing here and jut the lower jaw out. But whenever you leave anything in the patient's hands, it's really a less than ideal situation. And so the best way to get this done and do an oral appliance is through a dentist that is trained, that knows what they're doing. But the problem with that is there isn't a ton of them around yet that have specialized in dental sleep medicine. And there's a lot of follow-up appointments involved. So typically they'll start with just a little bit of a displacement here and then follow up with the patient periodically and slowly adjust it so they also don't cause too much jaw discomfort right off the bat. So it would involve a lot of follow-up appointments with the patient, going back to the dentist to have it adjusted, all of that.
Typically, these are not covered by insurance. There has to be a good amount of follow-up, continuing adjusting them. If you don't have healthy teeth upon which to use this, not an option for you. What?
Or any teeth.
Yeah, it's you cannot use it. You can't, it's not recommended for patients with TMJ disorders, the jaw, because it could make it worse. When you have somebody that sleeps with one of these on, expect a lot of drool. It's not going to work if they can't breathe through their nose, because typically you're supposed to breathe through your nose with this as well. So there's a lot of contraindications to this line of therapy. They might opt to do this instead of the mask, or if they'll try CPAP and realize it's not for them, then they might try this. I mean, essentially our patients, they get counseled on all their treatment options, and this is one of them. And patients will ask, our patients are getting more and more educated. I hate it's WebMD. We're all guilty of it, but they come in and it's like, you've got to somewhat, WebMD presents one picture of things, so it's like, let me tell you the truth. Let me tell you the clinician side of things, that these are not, there's a place for them and they can work, and they really, especially for patients that cannot tolerate PAP therapy, that are not going to be compliant, this is a good option. But, the patients that it will work for, it is limited. Another style of oral appliance is a tongue retaining device. It basically suctions your tongue and pulls it forward. Yeah, so your tongue is like stuck out like this while you sleep. That's more for patients that have like the tongue collapse issue. These forms of devices are really not used as much anymore. So it's really indicated for patients that have mild to moderate OSA that are not responsive or non-compliant with PAP, or they're just not a good candidate for PAP. Some patients, based on facial anomalies or whatever else is going on in their health, PAP isn't right for them. And so this is a good alternative. It is. But there's still a lot of things, contraindications, and it's not perfect. So you need to have adequate, healthy amount of teeth to be able to seat this thing on. No TMJ disorder. They need to have an adequate range of motion of their jaw and the dexterity to be able to put this thing in and take it out. Contraindications: if a person can't breathe through their nose, they can't use this because they should be able to breathe through their nose with this. If their apnea is central, then they can't use this because it's not going to do anything for them. Typically severe apnea, this isn't really working for them too much. And if they don't have any teeth, or if they don't have adequate healthy teeth to put this on. So some side effects of this is some patients complain of dry mouth because they typically are drooling all over the place with this thing. It can cause teeth pain. It can cause your teeth to start to shift and bite changes, and can cause discomfort with the jaw, especially in the morning. The patients should be monitored shortly after getting this, and as frequently as needed, to make sure that they're adapting to it, they're comfortable with it, it's working for them, the degree of displacement of their jaw is fine, that they're actually using it, that there's no side effects. Once a patient has this, they can undergo, it's recommended they undergo a sleep study, or even an HST, it would suffice, with their oral appliance in place to just figure out, is this working for them? You know, has this done what, at a minimum, what it should be doing to help reverse this patient's apnea? But HSTs are perfect for this kind of scenario, just to say yay or nay, does this patient still have apnea? It's generally recommended that they follow up with their specialist, a dental specialist, every so often, every 6 months or the first year, and then at least every year, just to make sure that everything's still going where it should, if necessary. Now, these things are expensive. My husband was fitted for one, and like just the initial fitting was $300, and then beyond that, I don't even know how much it was, because they comped us, because it's a really good friend that was just starting her her dental practice is very well established, but just establishing her apnea end of things. And she came to talk at my first conference, and it was really interesting, the process that they do to fit a patient for this. They have all these special machines that they have the patient breathe with, and they take impressions of their teeth and all this and that, and so they can better anticipate how to initially set the machine based on all the tests they're doing just in the office, and it's really interesting. I might have her come back again to talk at the next talk, because it was, you know, we hadn't seen a talk like that yet on the dental end of things. Before any type of treatment, they do need to undergo a sleep test, whether it be HST or in lab, just to document the presence of and severity of their apnea. It should be, the fitting of the oral appliance needs to be done by a qualified dental personnel, and they need to be able to follow up with the patients and know what they're doing. They need to have specialized training in dental sleep medicine. It's an additional certification that dentists have to do. Resolution of symptoms is the primary goal of therapy, and the indications for oral appliances are people that have snoring, or patients with mild to moderate OSA that prefer an oral appliance over PAP. Of course, these patients, they always recommend try CPAP first, They always recommend CPAP first for anything, and then if these patients don't respond to it, don't like it, then trying the oral appliance. If the patient's using an oral appliance for primary snoring, they don't need to do a follow-up test or follow-up sleep test, but if it's for apnea, then they should undergo a follow-up sleep test. So one of the things that they've come out with is what's called SomnoMed Matrix. It's designed to do the titration of degree of anterior displacement of the jaw on an overnight sleep test. So basically what this little thing is the patient comes in for a sleep test. You have their bite guard in place, and specialized bite guard that then attaches to this little blue piece. And a sleep tech, as you're monitoring their sleep, you're slowly, by a millimeter at a time, advancing their lower jaw until you see a resolution of their apnea. So that's something that you might come across. I believe St. Peter's does this, where you can do like the bite guard fitting on the night of the apnea. So you're saving a lot of time and back and forth for the patients of like, okay, let's move it a little bit, see how you do, come back in a few weeks. Let's move it a little bit, see how you do, come back in a few weeks. Like that's a pain in the butt. We're worried about compliance with PAP, and these patients have to come back a billion times to get fitted for these things. Well, it pretty much does it in a single night. So something that you might come across in apnea. So some other adjunctive therapies you might see are the nasal dilators. They're the ones that can be the nasal strips that are externally applied. There's also intranasal dilators. Basically what they do is just try to pop open the nose, especially if it's more of a nasal resistance. It can help with snoring. It's generally not effective to reduce or reverse apnea, but I've certainly had plenty of patients use like the nasal dilator strips in addition to their PAP. They found that they got a lot better outcomes with their PAP therapy by also integrating like the nasal strips with everything. A new thing that came out in recent years is known as Provent therapy. These are these little stickers that you apply and stick onto each nostril. And it kind of works and functions very similarly to PAP, but not nearly as strong. So when you breathe in, you have no resistance to inhalation, and then when you exhale, these little flaps close down and kind of create that resistance to exhale, creating that positive pressure, and following the same principle as PAP, but just it's not nearly as strong. Non-invasive, just little stickers. Yeah, the things people will do to avoid PAP. But the cool thing with this is they have created a way to be able to hook up your ancillary flow sensors and do a sleep test on patients on Provent therapy. St. Peter's was doing it for a little while, where they had these specialty things that you connect to the Provent, and you're able to do a sleep test on these patients to see the effectiveness of therapy, but also get a good valid flow signal in addition while they're wearing this. So surgery. Surgery is an option, especially in patients that have that anatomical predisposition that's causing their apnea. The only surgery that is 100% effective in treating apnea is a trach, because you are bypassing their upper airway. I actually had I completely forgot about this until yesterday when I was in the medical unit at Coxsackie, and they wanted me to do a sleep test on a patient that was trach to see if they still have apnea, to see whether or not they can get decannulated. Do you understand the absurdity of that, or would you like me to explain it? They're surgically already bypassing their apnea, and they wanted me to do a sleep test on them to see if they have apnea, to see if they can decannulate the dude. It can be considered as a secondary treatment. Of course, they're going to try less invasive techniques with the patient first. They want the patient to try PAP. They want to try an oral appliance if applicable, just to see if the patient can get away with that, because surgery is not without its side effects. It's not 100%. And these patients need to understand that any surgery poses plenty of risks, including death. So if we can have you sleep with a PAP on, that is definitely the lesser of two evils. And the other problem too is they need to be very clear that even though they're undergoing these surgeries, there is still a good chance they might still have apnea, where their apnea just might not be as bad as it was. So they might still need PAP at the conclusion of their surgeries, but they might not need as high of a level of PAP. And that needs to be very clearly explained to them, because they may not want to go through all of this. Some of them can cure the patients, but not all. And the patients need to go in there with full information that, because the problem is that sometimes you'll do the surgery and you'll have these patients that completely in their head think, there's no way I have apnea, I had the surgery. Well, you do. Like my aunt had the UPPP, the uvulopalatopharyngeoplasty, and basically what they did, in addition to that, they went in, they like roto-rooted her nose, and she said it was the most painful thing she's ever been through in her life, and she gave birth to a 10-pound baby. I was there. The kid was holding his head up when he was born. This was more painful. And I remember telling her, like, you have apnea. No, I don't. I had the surgery. It doesn't matter. You still have apnea. You have and it took her, I think, 10 years to finally, like, realize, like, oh, I should probably go get tested again. And severe apnea on her PAP, totally loving her PAP, compliant with therapy. But it can cause a delay in treatment as well, because, the surgery isn't going to always take care of it. So it can be used as an adjunctive therapy, meaning additional therapy or a sideline therapy. So if there's some type of anatomical abnormality that can be improved upon to help either, sometimes it'll correct the apnea, but in other times it'll just help a person tolerate their PAP better. Like if they have nasal polyps or a deviated septum, well, let's correct that, and then they're able to better tolerate a PAP and go to a nasal mask versus needing the full face. Make sense? So typical procedures that have been designed for apnea are designed to increase the size of the airway, and typically they're also sequentially staged, meaning like not one surgery will do it. Typically they'll do one surgery and then, okay, the plan is we're going to go back in and do this one next, but you got to heal from this one. So it's not always just like a one wham bam, thank you ma'am, you're done type of surgery. Sometimes they're undergoing 2 to 3 surgeries to get everything done and corrected the way to get that final end game. There's a lot of different types of surgeries depending on where anatomically the patient is affected and where the apnea is being caused by. So one of the more common ones is a maxillary and mandibular advancement, and basically what that is they break the jaw and move it forward. So those are the patients that have that very weak chin that causes, and those are typically your underweight patients, and so they break the jaw and they move it forward, and then they have to reset the bite for the upper and lower jaw. And that can have significant and really excellent outcomes for this surgery, because you really are doing a lot for them and opening up and improving the diameter of their airway. But most of the other surgeries out there are rarely curative and more just, and can improve other parameters. So some of the different procedures, the upper airway bypass, that's your trach, so cure, there you go. If there's issues with their nose, so septoplasty, rhinoplasty, turbinate reduction, that's basically they go in and they scrape all your turbinates to try to like open up your airs. If you have polyps, take the polyps out, those are gross. The uvulopalatopharyngeoplasty, or UPPP, UPP, that you'll see it written, UPPP.
Oh, wow.
Uvulopalatopharyngeoplasty. That was the surgery that was done, and it was huge when I first started in sleep, and everybody was having that done. And then the problem with that is that after some time had passed and there was some outcomes being reported on these patients, as they found that where they went in and removed a lot of the palate and the uvula and took out a lot of soft tissue, some scar tissue formed. And so in some of these patients, the long-term outcome was that their apnea actually became worse after scar tissue was formed. Advancing the palate, your hard palate, just trying to open up the airway. Tonsillectomy, adenoidectomy, not typically done for adults. It's really not effective in having any appreciable effect on apnea, but for kids, significant. It's have very good outcomes on a pediatric OSA, because the number one cause of pediatric OSA is tonsillar enlargement or an over-enlargement of the adenoids. And so going in and removing them, you'll typically see that really will clear up their apnea. When you have pediatric OSA, that's a huge issue all in of itself, with the growth retardation, and it can have a lot of significant negative consequences on a child by not getting the sleep that they need. Just behavior issues, misdiagnosis of ADHD because of their behavior issues, failure to thrive, failure to grow, failure to put on weight because they're not sleeping well. There's a lot of things that it's worth the payoff of getting them treated. They've tried doing implants in like the palate, so in the soft tissue of your upper airway, putting in implants that are stiffer to try to help the improve the collapsibility of the airway. There's a lot of different things that they've tried. They've gone in and tried to reduce the tongue, or like either ablate it or kind of hold it up and suspend it more upwards and forwards to help secure it. They've done the hyoid suspensions, the same thing. The advancement, bariatric surgery. But the maxillomandibular advancement is probably the one that has the best outcomes. And Dr. Kuhar will talk more in depth about all the surgeries when she comes. But this is also, sometimes they'll do this as not only for health reasons, but also for aesthetic reasons, because it just creates more balance to the face when you just bring that jaw out forward and just look at that neck. You see that neck, and then you just have a lot better responses. Right? They don't look like the same person. He might have had a nose job, right?
Yeah. I mean, while you're in there.
I know. This is her before, and that's her after.
Yeah,
that's, and now you're starting to see too, though, those patients when they walk in, it doesn't matter their size, but when you see the jaw like that. So typically after a person undergoes surgery, they would like to see them back into the sleep lab just to determine where they're at following surgery. Of course, we want them to heal first. After everything's healed and good to go, bring them back in just to see where they're at. Sometimes they'll do an HST on these patients because, again, they just want to see, do you have apnea and to what severity is it? But the long-term effectiveness is limited, and life brings on a lot of changes. So, you could have this surgical correction and it helps your anatomical variance, but then you gain weight and it can come back on. The growth of things regrow, scar tissue forms. There's a lot of factors that can change that can impact the long-term surgical success of this. But again, the person has to have some type of identifiable abnormality, anatomical abnormality causing their OSA. If the patient wants surgery, if they're medically stable enough to undergo surgery, and they have been unsuccessful or have rejected other forms. So when we say they fail CPAP, there really isn't a great definition of what failing CPAP means. Does it just mean that they don't want to do it, or that they're just not having success with it? It kind of encompasses everything. And patients should always be followed up with for effectiveness, resumption of symptoms, that type of thing. The hypoglossal nerve stimulation, that's the implanted pacemaker. And what it does is it's an implanted pacemaker that goes under the skin just like a cardiac pacemaker, and it's got a cable that goes up to their vagal nerve, and then another one that goes down to their intercostal muscles. So it picks up when the intercostal muscles are activated when the person's inhaling. It'll stimulate the vagal nerve to kind of jut the tongue forward and hold the tongue forward during each inhalation. That's kind of the basic gist of it. It's implanted underneath the skin. They wave a wand over it for when they're ready to go to bed, so it'll activate. And they can also adjust the level of stimulation, start off low and increase from there based on how they're feeling, whether or not they're still feeling symptomatic or whether or not they feel like their apnea is under control. So the process of this, and Dr. Kuhar, she does these. She's one of the first physicians in this area that started doing these. And so she'll come and talk to you. She has a whole talk on this, and she can go a lot more in depth and go through like the pre-surgical process, the screening process. She's got videos from these drug-induced sleep endoscopies, so they administer drugs to stimulate sleep in the exam room, and then they're visualizing where the airway collapse is being caused by, like in what the patient's anatomy, and well, if your collapse is being caused here, this isn't working for you. If it's being caused here, you have better surgical success. Like the screening process for this is ridiculous. It's like years process to get approved for this. They just started it, and what they found is it does work, and it does have good outcomes. It does help the average AHI reduce from 29 to 9. The oxygen desaturation index is improved. Patients typically feel better with it. So overall surgical success is pretty good, and they're really attributing that to how strict the screening process is for this. Like, that you can't be overweight, like your BMI has to be under a certain level, your apnea has to be like, you have to be of a certain age, and I mean they're so strict on the criteria to even start this process that's probably why they've had such success in the cases that have been completed so far. There's more reading here if you want to continue your reading on this. Typically patients do feel better and have reported it, better outcomes. You have to be 22 years of age or older. Your BMI has to be less than 32. Your OSA AHI has to be between 15 to 65. You've shown that you have failed CPAP. They've done the drug-induced sleep endoscopy or the DICE procedure to figure out where your collapse specifically is occurring when you do have an apneic event. And then they'll finally potentially approve you for the implant. Basically, the biggest thing is if a patient asks you about this, you know the gist of it. There's a lot of strict criteria to even be able to get approved for this. You know that it would be something to talk to your physician about, but they're still gonna, because patients are always curious about options aside from PAP. You know, what about that? What about that? Well, they still are gonna want you to do this. They're still going to want you to do this and show that either it's effective or it's not effective. It's expensive, you know, for the insurance to pay. That you really have to jump through the hoops. They typically will have the patient implant it, and about a month after they implant it, they'll have the patient come back into the office where they'll finally turn it on. So it's implanted and they don't even turn it on. They let the patient heal from the surgery first before they turn it on and activate it. And then they have the patient feel what it feels like in the office, that mild stimulation of the tongue. And they will do a titration of the device at a sleep lab. So St. Peter's and Albany Med have been doing these titrations. Interestingly enough, they cannot use RIP belts on these patients. That's where, I don't know if you were here when Erica was giving her some belts because they needed the old school piezo belts for these titrations, because the electricity of the RIP belts could alter the success of doing a titration of this device. So you're titrating the stimulation that it's providing. It's an outpatient surgery. It is having really good success. It's titratable. It's reversible. They can take it out if the patient doesn't like it. The patient doesn't have to turn it on. In terms of compliance, all you got to do is wave a wand when you're ready to go to bed. There's no putting a mask on, nothing like that. It can be performed as a standalone procedure or after other types of procedures have been done. But there is strict criteria. It is, a person is not able to necessarily get an MRI done with it in. And the battery does need to be replaced every 11 years, so they need to go back in for surgery at a minimum of every 11 years to get their battery replaced on the device. And, you know, there's still a question of its surgical success versus clinical success. It's new. The long-term data really isn't there yet. So what this is called is a micro CPAP, and it's basically this little thing you stick up in your nose. So I saw one on this like discount website, and it was like $5. So let me get it. Let me try it. It was the most uncomfortable thing I've ever stuck up my nose in my life. The plastic of it was incredibly stiff. I didn't feel any appreciable difference in anything with my breathing. Don't waste your money. It's still not FDA approved.
It's just like a fan inside of it.
I think the one I had just had like kind of like the Provent therapy where it had the things for inhale. It didn't have I don't think it had a battery in it or anything.
So it just creates a constant pressure.
Yeah, when you exhale. That's it for that one. Any questions?